is a great pleasure to be here today. I'm also a clinician. I work at a fertility center that does a lot of clinical diagnostic testing, but also a lot of research as well. And we try to transform ART by adopting disruptive technologies to improve the care that we provide to our patients. So the areas where nanopore sequencing can be used in the fertility care or reproductive care is in preconception genetic screening, diagnosis of fertility workup, both in male and female, as you already heard yesterday about the males, and also the reproductive microbiome as part of that. Today I will be talking about Preimplantation genetic testing and prenatal genetic testing using long-read sequencing. In our lab, we've been doing this for quite some time, since the first beta version that was released in 2014. But since 2016 until now, we've used MinION, GridION, and Preimplantation to solo. So the importance of this is very simple. The number of cycles worldwide of fertility treatments are increasing, and especially this is happening in the last 10 years with year over year around 30% increase, and around 2.5% of all babies born in the States are coming from assisted reproductive technologies. So preimplantation genetic testing for embryos gets a central role in this, mainly because the average age of parents is increasing, and the risks associated with that. The advancement in genetic testing is also increasing the diagnostic value, and we have no treatment for genetic disorders. Just a quick summary, around close to 7,000 genetic disorders with phenotypes are described today, and for all of these, there is basically no other cure, and ART can be used as a treatment for these disorders by analyzing the embryos and deselecting those that are affected. So the testing takes place after the embryos are biopsied and vitrified, and in between, all workup is done until the genetic testing results are available for choosing the right embryo for transfer. More than 70% of the patients that utilize assisted reproduction are over the age of 35, and this implicates the higher risk for aneuploidies in their gametes, especially for the females. And around 50% of the cycles utilize selection of embryos that are euploid for transfer to improve the success rate, reduce the miscarriage, and reduce the time to pregnancy. And also, by transferring one euploid embryo, we reduce the risk for multiple births. And this is just a graph that shows that with advancing maternal age, there is an exponential increase of the aneuploidy in the conception, with mirroring decrease of euploidy in the embryos. The big data from SART database shows that PGT-A, selecting euploid embryo, will increase the live birth rate per transfer and also live birth rate per cycle. This is the same in the Canadian database, with significant reduction in miscarriages to about 50% when a euploid embryo is transferred. So ART as a treatment can be used as selection for embryos, those that are affected by autosomal dominant or recessive disorders or aneuploid, all as a tool to prioritize in cases where there is late onset disorders, VUSs, or mosaicism. So the challenges here are the cases where the variants are de novo. There are repeat expansions, microdeletions, duplications, or balanced rearrangements. So talking about the balanced rearrangement, and this is where we focused our research, is because around 6% of the couples that are seen in infertility setting are carriers of recurrent pregnancy, balanced rearrangements. And these are relatively frequent in the general population as well, ranging between 1% to 4%. They usually have normal phenotype, with exception of some familial cases where in around 6% we see gene disruptions associated with phenotype, usually later in life. The problem becomes significant when they come to reproductive age and they suffer from infertility, recurrent pregnancy loss, or implantation failure, or offspring that is affected with microdeletion or duplication because of the higher proportion of unbalanced gametes that they produce. So the current NGS short-read technologies are very good at detection of unbalanced rearrangements. As you can see, it is obvious and all software is detected. However, when the embryo or the concept is balanced or normal, there is no distinction. So copy-neutral changes are not possible to be detected with this technology. So why is it important? It's first, patients that are going through the process would very much like to prevent the vertical transmission of the translocation. And at the end, there is no evidence that all balanced rearranged embryos will result in normal offspring. There are subtle microdeletions or duplications or gene disruptions at the breakpoint site that can lead to phenotypic abnormalities. So what we did, we used long-read nanopore sequencing at the time using MinION to develop a comprehensive PGT-SR, which stands for Preimplantation genetic screening for chromosomal rearrangements in couples at risk for unbalanced gametes or carriers for balanced translocations and inversions. With parental sequencing, we were able to identify the breakpoint sites and test the embryos to achieve the base pair resolution in detection of the breakpoints. With that, we were able to adopt the copy number assessment of the chromosomes of the embryos and obtained the PGT-A results and classify them as abnormal or unbalanced, euploid and mosaics, and also their carrier status of the balanced translocation. Using this, this approach, we were able to identify I will come to the next slide, but we were able to identify the breakpoints with minimum of 2 reads spanning the breakpoint. The range was between 3 and 10, and the average read length was 26 kilobases. So in IGV, you can notice that the breakpoints were clearly identified, and by using specifically designed primers, we were able to confirm the sites on both chromosomes. The copy number changes in embryos were adapted and were compared to the sequencing results of the short-read sequencing. And as you can see in the gray top copy number plots are shown the results from long-read sequencing, nanopore, MinION sequencing, and the bottom is from the short-read sequencing. So we were able to correctly identify the whole chromosome changes. However, with MinION, we were able to find the aberrations that were less than 10 megabases. So by using flexible multiplexing, we were able to identify the copy number changes using both MinION, GridION, and Promethean platforms. So far, we have identified 45 breakpoints, tested 380 embryos, out of which 53 were confirmed to be carriers of a balanced translocation. We were also able to identify gene disruption in one patient with a late onset phenotype. Another very interesting example is what I mentioned, de novo mutations, and on top of that, this was a microduplication of 260 kilobases, which causes Simpson-Golabi-Bemmel syndrome. Using long-read sequencing, we actually resolved the complex rearrangement associated with this duplication, was able to read haplotype and perform pre-implantation genetic diagnosis for a same-sex couple that was using ovum donor that was carrier of this duplication. With this, I would like to conclude, and I guess we'll have more time to discuss, that using long-read sequencing, we can resolve balanced rearrangements and perform comprehensive PGT-SR. Generic haplotyping is also available, and read-level haplotyping is very useful in de novo mutations, gonadal mosaicism, and in cases where parental DNA is not available. And using this platform, we can also perform aneuploidy testing and screening in embryos. I want to thank my team, and also thank you for the attention. Thank you.